Hello, and welcome to the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, and I am your moderator. We're very grateful to be partnered with the Faculty of Medicine and Dentistry Office of Lifelong Learning and Physician Learning Program for these rounds. And I just wanted to remind people that our next grand rounds is going to be on June 4, which will be live at the Bill Black Auditorium at the Glen Rose Hospital. And that actually will be a hybrid rounds if you cannot attend in person. So we hope to see you there. So I'm going to do the territorial acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehio or Cree, Niitsitapi or Blackfoot, Métis, Nakota or Stoney, Dene, Haudenosaunee or Iroquois, and Anishinaabe or Ojibwe Saulteaux lands that are now known as part of Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So a reminder, use the chat if you have a question about logistics of these rounds. And if you have a question for our speaker, please use the Q&A. And yeah, I'll introduce our speaker at this point. We're delighted to have Dr. Natalia Stavila, who is currently completing her child and adolescent psychiatry subspecialty training at the University of Alberta, where she also completed her general psychiatry residency and a Master of Science in Eating Disorders. As both a psychiatrist and a mom, she has grown increasingly concerned about the effects of excessive digital technology and social media on young people, and arguably the rest of us as well. So this concern inspired her scholarly project, which focuses on raising awareness about the importance of screening and counseling families about digital media use in accordance with current recommendations. Outside of work, she can usually be found serving as a full-time chauffeur to her daughter's sports and dance activities, and in quieter moments enjoys reading and hopes to one day take up tennis, an ambition strongly encouraged by her daughters, who look forward to the day that their mom is good enough for them to play together. So obviously a fun parent. I also want to add that Dr. Stavila, in my knowing her, is a very passionate and learned individual, and we look forward to your very topical presentation.
Good morning, everyone, and thank you, Dr. Liang, for your kind introduction, and for everyone who set time aside to watch this timely, I think, talk that I prepared today. Everyone can see my screen well, I hope.
Yes, it's perfect.
Okay, perfect. So my talk is Screening the Screen, Counseling Families in the Digital Age and Child and Adolescent Psychiatry Practice. I will not go over the objectives. I hope that people had a chance to review them. They were sent in the invitation in mail. Before I dive into my talk, I would like to kind of lay some of the definition of what I mean by digital ecosystem when I talk about it. So I'm referring to much more than the screen time. This includes internet, social media apps, video games, artificial intelligence, algorithms, and any other gadgets that involve interactive technologies. What makes this ecosystem different is that many of these tools are intentionally designed to capture our attention and to shape our behavior through features like autoplay, endless scrolls, notifications, and personalized algorithms. At the same time, many families are navigating fewer offline supports. and opportunities for children, such as accessible recreation centers, safe community spaces, free play, and accessible childcare. So parents are trying to set limits in an environment where digital tools are highly engaging, they're constantly available, and often filling real gaps in our daily lives. So over the past few decades, our understanding of digital media use has become much more nuanced. We've moved beyond simply asking how much screen time a child has and towards asking what kind of media they're using, why they're using it, and what context surrounds that use. In that sense, screen time is really just the visible tip of the iceberg. Beneath it are broader forces that shape children's digital experiences, including family routines, community norms, platform designs, policy decisions, and economic incentives. So when we talk about early digital immersion, we're not only talking about individual choices made by families, we're also talking about the larger ecosystem that makes digital technology increasingly present, accessible, and difficult to avoid from a very young age. In fact, in the US, 9 out of 10 children are introduced to a digital device before their first birthday. And in Canada, we're not doing much better. And nearly all children are exposed to screens by age 2, and about 50% of infants aged 6 to 11 months use a touchscreen daily. These are some, I don't know if you guys see the whole screen. This is a landmark study. It's called the ABCD study, or the Adolescent Brain Cognitive Development, the largest longitudinal investigation of adolescent health, brain, and cognitive development in the United States. It had 11,000 participants who were surveyed about their screen time and social media use, and the respondents were between age 9 and 15. So what this study established is that teens or young adolescents use about 7.7 hours of average recreational screen time per day. About 64% of kids between age 11 and 12, they had social media accounts that despite that social media, they have age restrictions, which I think most of them it's 13. 11% of them said that social media interfere with their academic performance, and 10% of them reported that cyberbullying and victimization was a problem for them, though I suspect in our sample that we work with, I think this number may be higher. In terms of patterns of use, they found that boys and girls engage with them differently, and boys are using mostly gaming and video watching, like YouTube watching, while girls are more into texting and social media. They also found that lower household income and lower parental education was linked to higher screen use. In terms of who reported a higher problematic devices use were the marginalized communities, including the Native Americans, the Black and Latino adolescents, as well as the LGBTQ plus community. The transgender youth reported plus 4.5 more hours daily use, while the homosexual and bisexual youth almost 4 hours more a day than the other kiddos. In terms of the mental health association that they found in this study that were associated with excessive screen time use and social media, they established that these kids are more likely to be depressed, to be anxious, to display ADHD symptoms, even conduct disorders and ODD. Eating disorders, suicidal behaviors, and even somatic complaints. They also established that kids who are excessively using these platforms are more likely to experiment early with cannabis, nicotine, and alcohol. So at the same time, the current digital ecosystem is receiving increasing public and scientific attention. Much of it is concerning. Almost every week, there are new studies published examining how digital technologies may affect young people, particularly in relationship to mental health, social and brain development. So for clinicians and our families that we work with, the challenge is not that there is too little information. It is that the information is evolving very quickly. It often feels overwhelming and can be difficult to translate into practical guidance. I certainly felt overwhelmed preparing for this talk because there were like papers after papers being released, and I had to sit down and actually focus and decide which one to choose because a lot of them are really good. This was hot off the press, actually. At the end of March, there was this trial in the US where Meta and YouTube were found liable in social media addiction trial, which is probably for the best. There is also increasing caregiver concern. In the 2023 CSMOT national poll, 70% of caregivers of children under 12 reporting being very or somewhat concerned about their child's screen time. Notably, the top 3 parent concerns were all related to digital media, including overuse of devices, social media use, internet safety, and they all superseded concerns related to depression, suicide, and bullying. This was a poll done, kind of similar theme. This is coming from the UK, and basically reveals the same concerns reported by the parents, that social media and excessive screen time was at the top of their concerns, and exposure to harmful content online was their second concern. One of the challenges, I guess, in this research area is that the impact of social media and excessive screen use is very difficult to study in a simple linear way. Digital media does not affect every child in the same way, as we'll discuss later. Its effects are being shaped by individual vulnerabilities and strengths, by the caregiver behaviors and their home environment, as well as community influences, and in general, broader platforms and policy environments. So rather than thinking only about like screen time, it is actually more helpful to consider the whole pattern of use, the quantity of time spent on the devices, the quality of content, the context in which these devices are being used, the level of interactivity, and the child's developmental stage. This is why the impact is very nuanced. The same technology may be helpful, neutral, or harmful depending on the child, the content, and the environment around them. It is also important, before again I dive into like some of the trade-offs associated with the technology, it is also important to acknowledge that social media is not uniformly harmful. For some young people, especially those who feel isolated offline, it can provide access to community, identity exploration, social support, and mental health information. This may be particularly meaningful for marginalized youth, including LGBTQ plus and people and youth with disabilities. At the same time, I want to highlight that we need to be careful what we mean by the word connection. Feeling connecting, we know that it doesn't equal being connected. Especially feeling connected online is not always the same as being connected in a reciprocal, supportive relationship. Some online relationships, such as parasocial relationships with influencers, can create a sense of false intimacy and belonging, but the relationship is essentially one-sided. So the clinical question is not simply whether a young person is connected online, but what kind of connection they have. Is it reciprocal? Is it supportive? Or is it replacing the kinds of interpersonal relationships that are important for their development, for regulation, and mental health overall? So now I'm going to move into some of the risks and trade-offs and unintended consequences of the digital age. And I went kind of into in a neurodevelopmental order, starting to focus more on like impact on language, cognition, executive functioning skills, and moving into the mental health impacts. So for the language development, this is one area where the type and context of screen use really matters. In this meta-analysis, greater overall screen time and background television were associated with lower language skills. This is important because background TV may seem passive, but it can reduce the amount and quality of caregiver-child interaction. On the other hand, educational programming and co-viewing with caregivers were associated with stronger language skills, as well as later age of screen exposure was also associated with better language outcomes, which is why it's important when we see families, especially with risk factors for neurodevelopmental vulnerabilities. If there is family history of language deficits, then we should inform the parents that maybe delaying introduction of screens is not a bad idea. This study adds a developmental and longitudinal lens rather than looking at associations across studies, as it followed children over time and asked whether early screen exposure predicted later outcomes. And what it stands out is that higher direct screen time at age of 2 was associated not only with poorer language and early educational outcomes by age 4.5, but also with later period difficulties, which helps us think that early screen use is not just about, it's not just a language issue, but also something that may have a broader developmental and social implications over time. In this next meta-analysis, this broadens the discussion beyond language and it looks at actually early childhood screen use context in relationship to their cognitive and psychosocial outcomes. The main finding is that not all screen exposure is the same. The program viewing and background television were negatively associated with cognitive outcomes, while program viewing, age-inappropriate content, and caregiver screen use during routines were negatively associated with psychosocial outcomes. This basically reinforces the idea that context really matters. It is not only the amount of screen time, but also what children are exposed to, whether the content is developmentally appropriate, or if the screens are present in the background, and also how the caregiver screen use may shape routines and interactions with their kiddos. This review actually looked at the relationship between digital media use and executive functioning and ADHD symptoms over time. And across many longitudinal studies, they found that significant association, most found a significant association, although the correlations were generally small. What is especially important here is that the relationship appears to be bidirectional. With high-frequency digital media use can increase the likelihood of later ADHD symptoms. And also children and adolescents with ADHD symptoms may also be more likely or more vulnerable to developing excessive or problematic media use patterns. Clinically, this is not about kind of blaming screens alone, but it's also recognizing that youth with attentional or self-regulation deficits may need more proactive support around media routines, boundaries, and replacement activities. And I think, again, this is very relevant to our practices. We do treat ADHD. We often optimize medications. We recommend psychotherapeutic interventions, and even those are insufficient. But I think what we're missing in clinical setting is that we are not exploring in detail like how much these kiddos are utilizing screens, because we can see they're more likely to have negative consequences from excessive use. This was a 2025 longitudinal cohort study here in Canada where they followed 3,300 kids and found that each additional hour of total screen time was associated with lower odds of achieving higher academic levels in reading and math. As with other studies, the effect sizes were small to modest. The relationship depends heavily on what children are doing on screens and whether the content is educational or non-educational, the context of use, and whether the caregivers were involved through co-viewing or mediation. This meta-analysis adds on the same theme. When researchers looked at across many longitudinal studies, social media use was associated with slightly lower academic achievement. And again, the effect size was small, but the direction of association was consistent enough to be clinically relevant. What is particularly useful here is that the study separates different types of screen activities. So TV viewing and video game play were more clearly linked with poor academic outcomes, while the total screen time alone showed no clear association. This is a book that I recently finished reading. I highly recommend for people interested in learning about this topic more. This was Jared Horvath who wrote the Digital Delusions, and he looked at how the ed tech has impacted the literacy and numeracy in younger generations. This is where the pattern becomes important, as like the research shows that across large international assessments such as PISA, TIMSS, and PEARLS, and the national testing such as the NAEP in the US, they found very similar signals repeated across different countries, subjects, grades, levels, and layers, and showed that routine digital exposure in instructional setting is often associated with weaker academic outcomes. And in some analysis, the relationship appeared to be dose responsive, meaning that the more exposure was associated with poorer outcomes. He also has a lovely Substack. If you don't have time to read books, he releases articles on a weekly basis. And one interesting recent paper that I read from him was looking at IQ levels, and Gen Z is the first generation in many decades that they're scoring lower on IQ testing than their predecessors, which is interesting. Now I'm going to move into the social emotional well-being impacts, and this was a recently released World Happiness Report. I'm a big fan of Jonathan Haidt, who wrote The Anxious Generation on this topic, and he has a section in this World Happiness Report. And again, people who are interested in this, highly encourage you to go take a look at this report. This basically described a decline in well-being among young people in North America and Western Europe, what they call the Anglosphere, compared with 15 years ago. And over the same period, the social media use has increased sharply, as we know. Of course, this does not prove that social media is the only cause. There have been many social, economic, educational, and family factors that are changing at the same time. However, the overlap was very difficult to ignore, according to this report, and it raises an important clinical and public health question. Is social media contributing to this decline, and for whom? Again, for people who want to find the answer, can take a look at this lovely written report. Gen Z themselves, this was a Harris poll where they this reflected how young people talk about the platforms themselves, and they said that they wished some major platforms had never existed, especially X, TikTok, and Snapchat. The concerns are not actually limited to the caregivers, to the researchers and physicians. Educators are also reporting digital media and personal devices and how they're affecting the classroom environment, especially with more distraction, reduced attention, concerns about academic performance. In this National Education Association poll in the UK, more than 90% of educators identified that student mental health was a major concern for them, and 90% of them supported restricting phones and personal devices during class. As well as the clinicians who are working in schools, they were noticing similar patterns in their practice, with social media often coming up in conversation about anxiety, depression, sleep disruption, and also addiction-like patterns of use. This study is a good example of how screen use and child behavior can influence each other over time. In this cohort study, a greater tablet use at the age 3.5 predicted more anger and frustration at age 4.5. Then higher anger and frustration at age 4.5 predicted greater tablet use at the age 5.5. So this is not simply a one-directional story where tablets cause dysregulation. It may also be that children who struggle more with frustration are more likely to be given or to seek out tablets as a way to regulate. And clinically for us, this is very important because tablet use can become part of this feedback loop that we, again, I think we encountered in our clinical practices, where distress leads to more screen time use, and more screen use may make emotion regulation harder to achieve over time in more adaptive ways. I certainly see a lot of parents struggling setting limits and boundaries with kids because they become dysregulated, so they're more likely to give in and provide them with tablets just to calm them down. This study looked at adolescents, and it found that there is a U-shaped relationship between after-school social media use and well-being across adolescence. In the younger grades, very high social media use was linked with greater odds of low well-being. However, in older adolescents, grades 10 to 11, no social media use was also associated with lower well-being. The most favorable well-being profile was seen with the moderate use, which makes sense developmentally, since we know that our youth now are connecting via social media. They find in it a sense of, again, belonging, especially in later adolescence. So the goal for us is not to completely eliminate use of social media and the digital devices. The goal is to have a balanced, intentional use that does not interfere with sleep, school, and offline relationships. This was actually a randomized clinical trial, also released, I think, within the last year or so. This gives us more of an intervention-focused perspective. And in this study, there were about 89 families in the intervention group, who handed over their smartphones and tablets for 2 weeks and reduced leisure screen media use to under 3 hours per week. While in the control group, which contained 91 children, they were encouraged to continue using screen use as per usual. And even over this short period of time, it was a short, again, study, but the intervention group, as you can see, showed greater improvement in total behavioral difficulties compared with the control group. This was again, also an experimental study done by Meta's internal research group in 2019, where they asked participants to deactivate their Facebook and Instagram for about a month. What they found at the end is that people who participated, they reported lower depression, anxiety, loneliness, and social comparison compared to the ones who didn't. Their media usage shifted to more TV and movie time. They have less community interactions online, and they actually shifted their engagement in person with friends and family. And they also reported having lower news knowledge, which may not be a bad idea with current constant negative stream of news that we are being faced with. So far, the evidence suggests that digital media is not inherently good or bad. Its effects depend on the child, on the context, the content, and the pattern of use. But one area of concern that becomes more specific is actually social media. And social media is different from many other forms of screen use because it is highly social, it is emotionally charged, it's algorithmically driven and constantly reinforcing. It can amplify comparison, normalize harmful behaviors, and expose young people to content that spreads rapidly through peer networks. So the next question is not just whether screens affect development, but whether social media can act as a vector for social contagion, particularly around body dissatisfaction, disordered eating, self-harm, and suicidal content. So taken together, the section that I'm just finishing shows that while the evidence is complex, it is not overly reassuring. In several domains, such as language learning, attention, emotional regulation, we see repeated signals that certain forms of digital media use can be harmful, especially when exposure is early, excessive, poorly supervised, and highly reinforcing. And from a public health perspective, even modest individual level effects matter, because when exposure is near universal, small increases in risk can translate into meaningful burden across the population, and that trickles down in our clinical settings. So the message is not that every child will be harmed or that every use is problematic. The message that I'm trying to convey is that widespread exposure to highly engaging digital environments can create clinically relevant harms at scale. And that is exactly why prevention, screening, and practical guidance belong in routine child and adolescent mental health care, in my humble opinion. This is mostly showing that the concerns extend far beyond mental health and learning. We know that screen use can affect physical health through several connected pathways. For example, having a device in the bedroom increases the likelihood of evening and nighttime use. And the research shows that about 63% of young adolescents have a TV or internet connected device in their bedroom. This can expose them to blue light, which leads to melatonin suppression. It decreases alertness and cognitive arousal and disrupts sleep. Screen time can also displace physical activity and can contribute to more sedentary routines, poor dietary patterns, and mindless snacking while they are in front of the screens. And over time, these behaviors contribute to higher BMI and elevated cardiometabolic risk, which again is an increasing concern, especially in the North American setting. And so far, we've reviewed the evidence linking the digital media with a range of developmental, mental health, academic, and physical health outcomes. And the next question that I have is, what do we do with this information clinically? So I'll start with the updated American Academy of Pediatrics technical report, which was released actually within the last few months. And they're building upon their 2016 policy statement. However, this one reflects a more current and nuanced understanding of children's digital lives. And rather than focusing only on screen time, this report highlights three major areas of scientific development, which included the individual differences, the caregiver behaviors, and the engagement-oriented digital ecosystems. They used a framework that was grounded in a socio-ecological model. And where they have the center is the child with their temperament, emotional regulation, developmental stage, and neurodiversity. Around the child, they put the caregivers whose own media use, parenting approach, stress level shape how children engage with technology. Beyond this is the digital ecosystem itself, including as I said, the algorithms, endless scrolls, notifications, misinformation, harmful content, etc. And finally, all of this sits within a broader system and structures such as school policies, government, childcare, economic incentives, and safety regulations. So as we move into professional guidance and counseling, the key message is that digital media use is not simply an individual family choice. It is shaped by children, caregivers, platforms, and systems. And our counseling needs to reflect that complexity. I will start with, because we're in Canada, I will start with our guidance that we have from the Canadian Pediatric Society. I don't think KCAP, as last time as I looked, KCAP did not have a position statement, so I think we're supposed to follow the Canadian Pediatric Society advisory, which offers a practical counseling framework for school-age children and adolescents using the 4 essential M's framework, which involves minimizing, mitigating, mindful use, and modeling. So they recommend age-based guardrails with no routine screen time under the age of 2. They recommend limiting screen time to about 1 hour per day for preschool age children, and for children 6 and older, keeping recreational screen time within a balanced 24-hour day. However, up to 2 hours per day, preferably. In terms of management, the CPS recommends creating and regularly reviewing the family media plan. They can be found online. Multiple associations have templates, and you can print them and provide your families with them. What I liked about the CPS that actually they recommend starting the family media plan early, even prenatally, because the family need to have time to think ahead before patterns become established. They basically say that setting meaningful limits when children are young and sharing them as a family is much easier than cutting back screen time later on. They recommend talking to parents to be present and engage when screens are used. When possible, to co-view with their kids and discuss content viewed, discourage multitasking, especially during homework. They recommend using parental controls, optimize privacy settings, accessing the passwords and login information, and to speak proactively about acceptable and unacceptable behaviors with their kiddos. Modeling. The CPS recommends to emphasize modeling safe and balanced habits by prioritizing outdoors activities, avoiding texting or headphones use in unsafe situations, and protecting screen-free family times during meal times especially, and keeping devices out of bedrooms at night. I'll say that this can be a sensitive conversation because parents are often doing their best in a highly digital environment. But framing it as a modeling rather than blame can help families see that small changes in adult habits can make the home environment healthier for the children and the family at large. They also recommend mindful use, where they recommend that discussions are held with the parents with focus on prioritizing routines, face-to-face interactions, prioritizing sleep and physical activity, to choose devices that were platforms that are educational, that they're social and active screen use rather than passive and asocial screen use. They recommend selecting developmentally appropriate content, engage in media activities with the kids when possible, such as playing video games together, and most importantly, to advocate for digital literacy programs in schools and childcare. This is where we help families recognize when screen use may be moving from ordinary use into problematic use. They advise monitoring for warning signs, which include distress or boredom, when technology is unavailable, intense conflict around limit setting, difficulty with stopping using screens, and screen use that starts to interfere with sleep, school, physical activity, or face-to-face relationships. It is also important to ask what happens emotionally after online interactions, games, or texting. And does the child seem more anxious, irritable, withdrawn, or dysregulated afterwards, or when the screens were removed from them? I will not go over ACAP recommendations. They are very consistent with CPS framework. I will just say that they emphasize two different things that are not super emphasized in the CPS. And they say to avoid screen times as pacifiers for babysitters as much as possible. And they also say that routine psychoeducation should be completed during our clinical interactions, especially, again, using the developmental stage, because, again, the impact will be different. With adolescents, they do recommend focusing on discussing with them the dangers of social media, in particularly related to social comparison, contagion effects, digital distraction, misinformation, sexually explicit media, sexting, cyberbullying, and the age of social media initiation. This was a US Surgeon General report. Again, I will not go into details. This was released in 2023. And where the U.S. Surgeon General position, it was that they at that time we did not have enough evidence to conclude that social media is sufficiently safe for children and adolescents. However, in 2024, he called for warning labels. I don't know if people saw it in the news, but it was all over the news that he advocated for warning labels on social media platforms, similar to those used for tobacco and alcohol, to make the potential mental health risks more visible to its users. What I think was important about this report is that the responsibility was not placed only on parents. The Surgeon General framed this as a shared responsibility with policymakers to strengthen safety standards, privacy protection, age-appropriate designs, digital literacy, and research funding. For technology companies, they needed to be more transparent and sharing data with independent researchers, and to design products with child safety and well-being in mind. For families and young people, also, they were advised to have to set tech-free zones to protect sleep, limit time on platforms, and blocking harmful content, and reaching out for help when needed. But the larger message was that individual behavior change is not enough. If the digital ecosystem creates risks at scale, then safety also has to be addressed at the platform level, policy, and public health level. This was I know we have psychologists in the audience, and they also have their recommendations specifically towards adolescents. And again, I will not read them all, but what was different in this report was that they do recommend that adolescents to be routinely screened for signs of problematic social media use that can impair their ability to engage in daily roles, routines, and may be present. Risk for some serious psychological harms over time. Again, I'll have my slides shared, so people who want to go back and view, they will have the ability to do so. This was the ABCD study that I referred to earlier. They also provided their recommendation. Again, they are very consistent with ACAP and CPS, but there were two a little bit different points here. They recommended to minimize using screens as disciplinary tool to control behaviors because their study revealed that taking away screens as punishment for bad behavior was associated with actually greater screen time and engagement with age-inappropriate media in the long run. They also emphasized the importance of family media plan to consider the children's developmental stage in mind, what electronic devices are in the household, and the family's needs for communication and schoolwork on electronic devices. And to do this, families can have regular and open conversations with adolescents about screens. So far, we have reviewed the evidence and potential harms, and then discussed the professional guidance and what major organizations recommend families and clinicians to do in response. The next question is whether this guidance is actually making its way into routine clinical practice. Are clinicians asking about screen time and digital media use, and do they feel comfortable counseling families? And what barriers make it difficult in real-world care? So this section looks at screening and counseling in current practice. I will starting with the Canadian study of pediatricians' awareness of screen time guidelines during the COVID-19 pandemic. And what it stood out for me was that the awareness of guidelines was really high, and the concern about health impacts was also very high amongst the respondents. But translating that concern into consistent counseling still depended on time and comfort, family motivation, and available supports. In the same study, the pediatrician reported a fairly high level of engagement and comfort. About 79% reported discussing screen time often or almost always in routine encounters. And all respondents described themselves as either comfortable and very comfortable discussing these issues with the families. This is very encouraging because it suggests that clinicians recognize this is a part of routine pediatric care and generally feel able to have this conversation. However, it also raises the next question. If awareness and comfort are relatively high, what still gets in the way of consistent counseling? And that brings us to practical barriers clinicians report in the real world practice. So this slide helps explain the gap between the comfort and implementation, and the main barriers were not the lack of clinician knowledge and training. Instead, the largest barriers were insufficient caregiver motivation or support, lack of time, and limited caregiver awareness of alternative activities. This is important clinically because this suggests that simply giving clinicians more information may not be enough. Families need practical, realistic strategies that fit into daily routines, especially when screens are serving as a function such as occupying children, reducing conflict in the families, or helping parents manage competing demands. So effective counseling has to be collaborative and concrete. We need to ask what screens are doing for the family, identifying one small change that feels achievable, and connect recommendations to families' own goals around sleep, behaviors, academic work, and well-being. This study brings the issue into psychiatry training specifically. It suggests that social media assessment remains an underdeveloped part of the psychiatric interview, despite its growing relevance in youth mental health. In this survey, only 10% of trainees before COVID and 20% during COVID reported asking about social media use during patient evaluations. Among the paired respondents, Screening increased from 13 to 27%. However, this change was deemed to be not statistically significant. So even during major sociocultural shifts, when digital media use was rapidly expanding, the interview practices did not substantially adapt. And the takeaway home message was that we need to teach and normalize social media assessments as part of our routine psychiatric interview, especially I think in child and adolescent psychiatry training. That means asking not only about the time spent online, but also platforms, content, sleep disruption, mood effects, social comparison, etc. And this was a quality improvement project that I found. This one showed that routine social media screening can be built into clinical care when it is treated as a system level workflow issue, not just as an individual clinician preference. This team set a clear goal to increase screening and counseling at adolescent well visits from 0 to 50% within 6 months, and then sustain it. They used a plan to do study act cycle and added documentation macros in their EMR to track both social media screening and anticipatory guidance. The results were encouraging. The screening exceeded the 50% target they established within 1 month, and sustained screening above 50% was achieved after 9 months, and this was maintained for more than a year. The anticipatory guidance was harder to capture, and they suspected that this might have been underreported, though the project still shows that simple workflow changes can make screening much more consistent. So I hope that, again, by relaying the above, again, information, I am making a case for routine screening of digital technology use in child psychiatry. Like in our setting, we already screen for sleep, school functioning, peer relationships, family stress, and substance use because we know these are modifiable risk factors for mental health. And digital media now belongs in the same category. For school-age children and teens, especially those with emotional regulation difficulties, anxiety, mood symptoms, ADHD, and autism, screen use may become more reinforcing, may be harder to regulate, and more likely to interfere with functioning. In many ways, the online risks mirrors their offline risks. So youth who are vulnerable offline may also be more vulnerable to adverse experiences online. So screening should assess both exposure and impact, not just how many hours, but what kind of content is being accessed, when is it used, by whom, with whom, and what is it doing to sleep, mood, attention, schoolwork, etc. And when preventive guidance is hard to access, and we all know, at least in our province, a lot of our families don't have access to primary care, including family medicine or pediatricians. Child psychiatrists are well positioned to identify these patterns early, to support healthier habits and help families make practical changes before screen use becomes another driver of distress or impairment. So this brings me to our local context, a project conducted by me under the supervision and support of Dr. Morissette. So given the evidence and the professional guidance, we wanted to understand what screening and counseling currently looks in our local practices. This project is a cross-sectional anonymous survey of child and adolescent psychiatrists affiliated with the University of Alberta program and Recovery Alberta. And our goal was to establish a local baseline. For example, how often clinicians ask about digital media and social media use, how comfortable they feel with counseling families, what barriers they encounter, and what supports would make it easier for them. The survey also asks about the awareness, perceived concerns, and desired resources for the clinicians. And the purpose of our study was mostly practical. We're not just trying to describe a problem. We're trying to identify where quality improvement efforts could support more consistent screening, counseling, and family guidance in routine child psychiatry care. Here I'm attaching some screening tools. I know that this is not widely publicized, but this is actually published on the Alberta Health Services. There is a page dedicated to it, and these are some screening tools that you can consider printing and having kids or families complete even before they come to see you for a new consultation for time saving. I particularly liked the internet addiction test because this classifies severity on the continuum rather than simply yes, no result. As you can see, it classifies it from a balanced use to pathological use and can inform your counseling. This also I found out recently during my preparation for this talk. I recommend people looking at this page. It's quite resourceful. I was not aware of its existence, but I think for our clinical practice is very relevant. And again, I do encourage people to go and look at the work that they're doing. They have a team of researchers as well. Maybe collaborations or just again, resources for the families that we see. So my takeaways are that digital media and social media platforms are omnipresent in youth lives. Their impact on development and mental health is heterogeneous. It's bidirectional and context dependent. The youth with pre-existing mental health conditions are particularly vulnerable to problematic use, addictive design features, and adverse psychosocial outcomes. There is evidence-informed professional guidance for us. Screening and counseling remains underused due to clinical and system-level barriers. And clinicians have an important opportunity to intervene by routinely asking about digital media use, assessing risk, and providing developmentally appropriate family-centered guidance. And I just wanted to end on a hopeful note. This is a short video, part of Roger's campaign featuring our hero, Connor McDavid, who is raising awareness about unhealthy social media use and the opportunities that can be lost when screens take up too much space in young people's life. I think this is very crucial for cultural shift because when athletes, our heroes, idols, public figures are starting to name a problem openly, I think it becomes easier for young people to reflect on their own habits without shame or blame. And my hope is that this awareness continues to trickle down into homes, schools, clinics, so that we can help children and adolescents to use technology in ways that support their development rather than quietly displacing it. So I hope that this will work. I think I will. Sorry for the technical difficulties.
That's a good question. Definitely depends on the day. I'm going to go anywhere between 2 hours and 3 hours or something like that. Wow, that's alarming. Live so much on our phones, on devices, and for a lot of people, it's the way they stay connected with the world. What I use my phone mostly for, to talk to friends back home, talk to mom and dad. I know I sleep so much better when I'm not on my phone, in the time leading up to bed. So I'll just go upstairs, put my phone away, turn my phone on to sleep mode. Don't see any texts, don't see any notifications, kind of out of sight, out of mind. Those habits or those tools kind of in place, it feels so much better. Some of the best memories I have still this day are a neighborhood friends playing together. There's a street hockey game going on in the neighborhood. You can't do that playing on a screen.
Perfect. And I think I'm near the end. So thank you, everyone. Let's help raise kids who are not tech-free, but tech-wise. And I just wanted to say special thanks to Dr. Morissette. He's been a source of inspiration for me from my second year. He's been incredibly supportive with this educational and scholarly project of mine, to Dr. Alice Leung for kindly distributing the survey, and for everyone who had completed our survey. This is a QR code for those who maybe haven't had the chance to take a look. My survey ends tomorrow, and if you think you're eligible, please, it only takes 2 to 3 minutes to complete. So I would really appreciate your support with this. And I have some bibliotherapy that you can recommend to your families. The Digital Delusion, as I referred, The Amazing Generation is actually for teens, and it's written by the same author who wrote The Anxious Generation. And I love this book. I actually read it with my oldest daughter. This is for parents, 10 Rules for Raising Kids in a High-Tech World. And this is a very new book. I haven't read myself, but I heard good reviews. It's 5 Habits on the Tech-Ready Family. And these are my references, and thank you very much.
Thank you, Dr. Stavila, for this very enlightening and presentation. You did such broad scanning, and these are such wonderful, guidance and resources that you've provided. So I think, as you've mentioned, we will distribute. But we do have at least a couple of questions. And I guess just a reminder because I know Dr. Natasha is going to remind us too that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians. And then remember to do your evaluation as well. So we have one question. For children who are presenting with symptoms of ADD, do you encourage a reduction in screen time as a first step prior to assessing for ADD?
Yeah, I think this is a tricky one. Like, I think, again, based on the existing evidence, it is suggestive that it impacts our executive functioning skills and our attention fragmentation. I think ideally, if we can, I think it would make sense. However, given that some kids can be quite impaired by the symptoms, and they may need more precipitous kind of like intervention, I would not, at this moment, I think I would not delay it, though a part of my biopsychosocial treatment recommendations, I would tell the parent that maybe the treatment can be more optimized if we are trying to reduce. Though I acknowledge that, having excessive time spent on these devices can be a confounder and may influence the severity of the ADHD symptoms. However, again, it is hard to know for sure how much it is impacting. And I think, again, ideally, yes, but clinically, I don't think I would delay treatment or like assessing and confirming the diagnosis.
Thank you. So, okay, so Dr. Rabi has a comment and question. Thanks for a wonderful talk. This is a topic that he also finds extremely important. Oh, this is a big question. What do you think could be a practical solution to this worldwide problem?
Yeah. So I am a firm believer that, this, I think based on the talk, I think we all I think that was my conclusion. This is a complex problem that comes from so many different levels. And I think that complex problems require complex solutions. And I do like Jonathan Haidt's kind of view that this has to be a collective action thing. So it's not just us. I think us as clinicians are just like one pin in the wheel. This is not just like a parent problem or an individual problem. This will take like a collective action by policymakers, governments, us as clinicians. And I think we just have to start somewhere and with things that we can control. And in the clinical setting, what I would say is that I would try with something tangible, something that I know it's actionable. So the family media plan, I think it's something that we can actually do, like provide the parents with. It's something that they can hold into their hands and review. I would also, one tangible thing would be like, I will advise the parents to keep screens outside of the bedrooms. I think this is easy, but a very impactful thing. Having screen-free meal times and allow for parents to connect with their kids, have conversations. I think those again are two or a few clinical tips that I can give to the families, and that's a small change that I can do. I know like worldwide I can't impact, but I think if we all collectively do our own kind of work, I think maybe the problem will be tackled a little bit.
Okay, we have another, a comment, saying that they really appreciate the practicality of your presentation. And then Dr. Nico is saying, a great presentation. one question is around the point that one of the organizations made about not using screen time as discipline. Where he's working with the family, recently counseled them to consider short-term consequences if the young person cannot get off the iPad as directed, like taking away privileges the next day. That would be in line with logical consequences, but maybe some relational downsides and dysregulation. Does anyone offer alternatives, then given the situation?
Yeah, that's why I highlighted that because I thought it was very different. Like that was based on that ABCD study that they found that again, using devices, kind of like taking them away as a punishment. And we know the negative consequences don't act as well as the positive reinforcers. I don't have an alternative. I would still like even in my household, I know that the kids respond to like if I say like no more, you're not allowed to watch today your favorite show for like I don't for doing something. I think it works, but I know that this kind of solutions don't work for every child. So I think I hope that the parents know their child better. They know what consequences work and what don't work. And it looks like the evidence shows that for some kids this don't work and they actually get like in the long term are not that helpful. I don't know if this answered your question, Mark.
Yeah, that might he has alluded to maybe that the relational context, right? Because if you have a really good relationship with your kid, at times taking away screen time might have a different impact than if you're already at odds, and that's just one more thing that could become a big fight. And then Dr. Van Riper asked, I wonder if you could frame it as earning the privilege for the next day by getting off in time rather than having taken away. So some suggestions here. Yeah,
so this would be used as a positive reinforcer rather than a negative consequence, which again, we know from CBD model that positive reinforcers work better. So yeah, reframing. I like that idea. Thank you, Dr. Van Riper.
Yeah, I know we're running a little bit over time, but I do have one, this is another big question. What do you think about national guidelines for limiting access to social media based on age? Because as you know, Australia has limited, Canada's thinking, and I don't know if you have an opinion on that.
A lot of countries are actually also considering, I think France is another one and some other European countries. I think I'm ambivalent. I know that kids are smart. They use VPNs and placing those, unless the whole globe is doing it, I think yes, may work. But with the VPN use, they can say that they're in the different country and they will also access it. So I don't know if the solutions will ultimately be that impactful.
Okay, well, thank you again for this really informative and helpful presentation. I just wanted to mention that this is the last time that I'm moderating these rounds. It's been a wonderful learning journey with all of you, and stay tuned for what future iterations of these rounds may look like.
Thank you again, everyone.